Hello, my name is Dr. Mata. I'm an adult neurologist at Chipata Level 1 Hospital, and today we will talk about cognitive disorders, an approach to cognitive disorders, and very briefly about some of the more common cognitive disorders that you can expect to encounter during the course of your clinical practice. Our objectives are to define what we mean when we talk about cognitive disorders. We will discuss the difference between reversible and irreversible cognitive disorders. We'll discuss non-dementia cognitive disorders, the difference between delirium and dementia. We'll discuss the various dementias and their symptoms, and we'll talk briefly about treatment options for the various cognitive disorders that we're going to discuss. When we talk about cognitive disorders, really we're talking about anything that involves an assault or an injury to the brain. Cognition is about the different cognitive domains that allow us to function as individuals, as independent individuals, and as part of a collective. So classically, we think about memory and learning when we think about cognition. And as such, the loss of memory and learning is the most common thread in all the cognitive disorders that we're going to discuss. Some cognitive disorders are temporary or reversible, and some are permanent or irreversible, and we'll discuss which ones are which as we go forward. Non-dementia cognitive disorders. Here we'll talk about the three that we need to think about. So mild cognitive impairment, delirium, and pseudo-dementia. Mild cognitive impairment, or MCI, has a subtle onset, and it is not the result of normal aging. Some literature describes mild cognitive impairment as the zone between normal aging and Alzheimer's disease, which is not really true. But you are more likely to progress to dementia if you have mild cognitive impairment. And the difference really is when you have mild cognitive impairment, you have some dysfunction to one or more of your cognitive domains, whether this is attention, whether this is memory, whether this is behavior, executive function, your visual spatial, or your language. But you do not have functional impairment, meaning you are still able to function independently. Your activities of daily living and your instrumental activities of daily living are still preserved. So you are able to feed and bathe yourself, you can dress yourself, you can hold down a job, you can go to school, you can hold down relationships, but you have some cognitive impairment which you can actually identify if we were to perform screening tests or neuropsychological evaluations on you. Whereas with dementia, you have this cognitive impairment and you have loss of some, at least, of your activities of daily living. So mild cognitive impairment, amnesia, forgetfulness is probably the hallmark that most of us will first see. Of importance, especially in the hospital setting, for the non-dementia cognitive disorders is delirium. Now, delirium is an acute onset, acute being in the sense of hours, days to weeks, not more than 3 months in terms of duration, alteration in cognition. It's really characterized by a disturbance of consciousness and a change in cognition. So you have patients who are either hypoactive or hyperactive, meaning that they are either patients who are just sleepy all the time, or they are not sleeping at all, or they fluctuate, they wax and wane between somnolence and hyperactivity. Other symptoms, you may find a patient who have slurred speech, they might be having nonsensical thoughts, they have reversal of their sleep cycles, hallucinations could be manifest in delirium. A classic example of a delirium is delirium tremens that you see in patients who are intoxicated or withdrawing from narcotics, alcohol, and things like that. In elderly people, delirium is very important to look for because it is a very important cause of hospitalization. So you must always consider a delirious process in a patient who presents to your hospital, especially if they're elderly and they're presenting with cognitive impairment. You must look for a cause. It could be infectious. Elderly people, something as simple as a urinary tract infection can lead to delirium. Look for metabolic derangements, electrolytes, glucose, thyroid dysfunction, vitamin deficiencies. Look for these as potential causes of a delirious process. Also look for things like subclinical seizures, which could present with this impaired cognition. Pseudodementia is a type of cognitive disorder that is most often linked to an underlying functional psychiatric illness such as depression. So there's a lot of overlap in the way patients present, both for neurologic conditions and psychiatric conditions. So it's very easy to get confused. So depression on its own can look like cognitive impairment, and cognitive impairment can look like depression and can have depression as a component of it as well. So it's really good to take a multidisciplinary approach when you're attending to patients in this regard. But patients with pseudodementia tend to be withdrawn, they are apathetic, but can also be anxious and agitated. So again, very, very similar to, for example, patients with Alzheimer's, patients with frontotemporal dementia. Sometimes you can get clues in the way a patient responds to you when you are taking your history. A patient with a dementia, for example, will genuinely most of the time be trying to answer your questions, whereas sometimes patients with pseudo-dementia will not make an effort and they would respond with a lot of I don't knows versus I can't remember. But it's not an easy distinction to make. When we talk about dementia, this is a chronic condition that develops over years. So dementia is a chronic condition. At a minimum, it's 12 months and above. Most patients who are presenting with dementia have probably been symptomatic for 3 to 5 years before they present to most healthcare providers with symptoms. Dementias are usually primary, they are progressive, and they are irreversible. And Alzheimer's disease accounts for most of the dementia that we see. Depending on different literature, it's anywhere from 60 to 70 to as high as 60 to 80% of all dementias, not only in the US, but in the world. Are there reversible dementias? Potentially, yes. There are some that you must always look for in a patient who presents with a dementia process, and we'll highlight 2 of them: normal pressure hydrocephalus and vitamin B12 deficiency. And this is where imaging is really important because it might help you differentiate between a reversible and a non-reversible dementia. So normal pressure hydrocephalus, NPH, usually presents with a classic triad of patients who are wet, wobbly, and wonky, just really meaning they have problems with urinary incontinence, they have an apraxic gait, which is the wobbly, and the wonky, which is the dementia. When you do a CT scan, you find that these patients have huge ventricles, but it's a normal pressure hydrocephalus, so the enlargement is through all the ventricles. So things like headaches may not be a classic feature versus someone who has an obstructive hydrocephalus with a raised intracranial pressure. But they do present with features very classic of a dementia, so they begin to have difficulties with activities of daily living, they experience dulling of personality and a lack of motivation. This is potentially treatable with neurosurgery to put in a shunt to drain the excessive cerebrospinal fluid. Vitamin B12 deficiency, the most commonly caused by pernicious anemia, is a potentially reversible cause of dementia. It is difficult to get vitamin B12 deficiency because all of us, whether you are a meat eater or not, generally have around 2 years worth of stored vitamin B12. So you would have to be completely deficient of vitamin B12 for quite a long time before you are asymptomatic. But it's something to think about, especially in patients who have other autoimmune conditions. So when you see one autoimmune condition such as diabetes type 1, such as thyroiditis, you must look for other autoimmune conditions. And remember, pernicious anemia is an autoimmune condition. So you must think about it in patients who are presenting with anemia and cognitive impairment. Think of it as a possible cause because it is very readily treatable. These patients might present with paresthesias. Classically, it starts off as a peripheral neuropathy in the extremities. Again, once you hear that in the history, think about possibly B12. If you're going to look for B12, look for folate deficiency as well. On the MRI, you may sometimes find lesions in the optic nerve and cerebral white matter, but this requires someone who has experience to look for those things on imaging. We treat this with vitamin B12 replacement and should be started immediately and continued throughout the patient's life. For the irreversible dementias, although we should probably actually update this slide because over time there will be therapies, and there are currently therapies that are potentially going to start getting us to the point of reversing dementia by removing the abnormal proteins that are the cause of most of the dementias that we see. But generally speaking, in terms of the classic dementias, the focus is on quality of life. It is on symptom relief, slowing progression, and supporting assistance to the patient and to their caregivers. So the classic dementias that we talk about would be your Alzheimer's disease, vascular dementia, frontotemporal lobe dementia, Parkinson's dementia, diffuse Lewy body disease, the rapidly progressive dementia such as Creutzfeldt-Jakob disease, and AIDS dementia, now more appropriately called HIV-associated neurodegeneration or HAND. And then you still do have things like Wernicke-Korsakoff syndrome and dementia associated with Huntington's disease. So just talking a little bit about each one of these. So again, Alzheimer's disease is the most prevalent dementia, and it used to be a diagnosis of exclusion once you had looked for other things, and we still do look for other things, but we now have blood and CSF biomarkers that look for the cause of Alzheimer's. So in CSF, we're looking for abnormal tau and amyloid levels, and depending on the levels that you find, these can tell us if someone has Alzheimer's disease even before they have clinical symptoms of dementia, which is a game changer really in terms of being able to make a diagnosis and to plan treatment. So this is now something that we can diagnose using a very sensitive, very specific test. These are not yet easily and readily available, especially in settings like ours, but they will over time become more so you must be aware of them. So now moving from CSF biomarkers to actually blood biomarkers, which probably have much more acceptability in our settings. In terms of risk factors for dementia, age is your biggest risk factor. The older you are, the more likely you are to have dementia, Alzheimer's. So it's not that your age causes it, but the fact that you have lived long enough to have enough abnormal beta amyloid and tau deposits, then you are more likely to develop dementia, Alzheimer's particularly. But other things such as having poor education, Being female also increases your risk of developing Alzheimer's dementia. There are genetic aspects as well that we must talk about. There are some genes that increase your risk of having Alzheimer's dementia, such as the ApoE4 gene, whereas the ApoE2 and 3 are somewhat protective if you have those two. But if you have an ApoE3, know that it causes dementia, Alzheimer's, but it increases your risk of developing Alzheimer's dementia. In terms of presentation, so you do tend to see some classic features. So the amnestic syndrome with loss of episodic memory is a classic feature of Alzheimer's disease, but you also have patients presenting with agnosia, the impaired ability to recognize or identify familiar objects and people in the absence of a visual or hearing impairment. So someone looks at a cup and they fail to recognize that it's a cup. They can tell you what it's for, but they can't tell you what it is. So language and speech, so aphasia can be a feature of Alzheimer's disease. Amnesia, like we've mentioned, is a classic presentation. Apraxia, the inability to carry out motor activities despite intact motor functions. There are a lot of other ways patients with Alzheimer's dementia present, again depending on the different cognitive domain that is affected. And there are some features such as sundowning, where towards the end of the day patients with Alzheimer's tend to become more irritable. The cognition seems to be worse towards late afternoon, early evening. Vascular dementia has been called a lot of things as well, such as multi-infarct dementia, kind of leaning into the fact that this is primarily because of injury to the brain arising from small strokes that over time lead to loss of enough brain tissue that you present with a dementia syndrome. So you have this memory loss being the primary presentation, and once you do imaging of the brain, you have these small vessel changes that are classic of multiple infarct. FTD, frontal temporal lobe dementia, is, as the name suggests, a type of dementia that arises because of primarily loss of the frontotemporal lobes. And classically, this is a type of dementia that presents with very strong behavioral symptoms and loss of executive function. So these people are prone to loss of judgment, where they have very poor decision making, very poor impulse control, and loss of social norms. And the management of frontotemporal dementia is really focused on behavioral management more than anything else. When we think about conditions like Parkinson's, we do think mostly about the motor aspects, but you can get dementia as part of the Parkinson's disease process. So this usually presents quite late down the course. So something to think about in all of our Parkinson's patients. It's not just about the motor symptoms, they are also prone to dementia over time. Lewy body disease is a form of dementia that presents with both cognitive impairment and also extrapyramidal effects. So it presents really very similar to Parkinson's. So there are a lot of Parkinsonian syndromes with tremors, with gait abnormalities. And these patients also present quite heavily with hallucinations. They have a very strong tendency to fall, and they have a fluctuation in alertness early in the disease. The downward course is more rapid than you would see in other types of dementia, usually around 5 to 8 years from onset. And really the the extrapyramidal signs kind of separate it from Alzheimer's disease. You don't get a lot of extrapyramidal features with Alzheimer's disease. Creutzfeldt-Jakob disease is the classic rapidly progressive dementia that is caused by prion disease. These patients will decline quite precipitously in less than 12 months from a state of a normal cognitive functional state to severe functional impairment, and prion diseases are generally universally fatal. HIV dementia or HIV-associated neurodegeneration, and is something that we do think about in the context of HIV because the virus itself crosses the blood-brain barrier quite early in the disease course, and the CNS actually acts as a sanctuary site where a virus that has had minimal exposure to most antiretrovirals hides essentially and causes injury to the brain that presents with memory loss, executive function impairment over time. Wernicke-Korsakoff syndrome, most often thought around with the abuse of alcohol, but this usually presents decades after the person starts drinking alcohol. There is a tendency sometimes to see people come in acutely impaired and label them as having Wernicke-Korsakoffs, which is not true. So we need to remember that when we're talking about Wernicke's encephalopathy, it results in motor problems related to alcohol abuse. So you must have certain features for you to label someone that they have Wernicke's encephalopathy. You are looking for ataxia, you're looking for ophthalmoplegia with nystagmus. And patients with Korsakoff syndrome, you're looking for confabulation as they attempt to answer questions in an attempt to cover their severe short-term memory loss. Huntington's disease, again, very similar to Parkinson's disease in terms of when we think about motor dysfunction in neurology, we focus on the motor aspect, but most of these conditions will present with a dementia, remember these are all neurodegenerative. So if you are losing neurons, it's going to affect other aspects of function. So as you lose motor function, you will lose cognition as well. So it's important that even in patients that you are managing for other conditions, you are assessing for cognitive impairment, and that's why we do a neurologic examination and a mental state examination so that you have a sense of the cognitive function of your patient. Very briefly, when we think around what should my approach to diagnosis be in patients presenting with cognitive impairment, your history is still your primary source of information. So you must get a detailed sequential history, starting with when symptoms started, what were the initial presentations. This helps you try to identify which cognitive domain was affected first and which cognitive domains followed. So you want to try as much as possible to get information in sequence. And for you to do this, you must speak to someone who will give you a collateral history. The patient themselves may not be the most reliable person to obtain this history, but you still must try to engage with them and get their perspective of what's been happening. You have to take a very detailed drug and past medical history, because a lot of the times, especially patients who present with an acute to rapidly progressive, you want to look at all the medications that they are taking and make sure that they're not on any medication that is actually causing the cognitive impairment. Look for comorbid conditions, especially hypertension and diabetes, not only as a cause of the cognitive impairment, but also something that you must manage to try to reduce progression. So if they're hypertensive, they're diabetic, you must look for that and see how it is being managed. We usually start by performing some kind of screening test, such as the mini mental state examination or the MOCA, to see how cognitively impaired someone is. And this should ideally be followed by formal neuropsychologic testing, which will better localize which cognitive domain is most affected. And then you are also looking for reversible causes. So you must do some basic blood work, full blood count, kidney, liver, HIV, look for infectious causes like syphilis, and look for B12 like we mentioned. Imaging, CT versus MRI, both are quite useful. If easily accessible, my preference is to ask for an MRI because it gives me more information, and in the event that the patient should have something reversible, for example, if someone has normal pressure hydrocephalus and they require neurosurgical intervention, I would already have an MRI that the neurosurgeon can use to make certain therapeutic decisions, especially in the context of the costs associated with this test. Asking a patient to do a CT and then an MRI versus asking them to do an MRI as a one-off might be easier to ask for an MRI. Like we mentioned, now we are able to do CSF biomarkers for Alzheimer's disease, so tau, amyloid, and soon we should have in the clinical setting access to blood biomarkers that will be really helpful in the diagnosis of the biologic diagnosis of Alzheimer's disease, the most common type of Alzheimer's. And then we're thinking about things like functional neuroimaging, functional PET scans that help me localize where the injury is, what part of my brain is not working the way that we would want it to work. In terms of treatment of cognitive impairment, this is really very broad. I'd advise us to read individually. So if I have thyroid dysfunction, I manage the thyroid dysfunction. If it's a B12 deficiency, I manage the B12 deficiency. But it's really about the safety of the patient in the hospital and in the home care setting. We must, as much as possible, identify and reverse any reversible causes when possible. Daily care as needed. If someone is having impairment in activities of daily living, that means that they must be supported in those areas of loss of daily living activities. We must be able to manage symptoms as they arise, using medication as appropriate. Some medications, for example, in Alzheimer's disease, there are therapies that have been tried. The anticholinesterase inhibitors, donepezil, for example, is a drug that we use quite commonly. It does not cure or reverse the Alzheimer's, but may reduce the symptoms and allow the patient to remain functional, independent as long as possible. So this is usually used in mild dementia. And as it progresses, there are drugs that have been classically used for quite some time, such as memantine. And now we have newer drugs that are coming onto the market. These are antibody therapies such as lecanemab and that family of drugs that are quite promising in terms of what they may be able to do to reverse amyloid and tau deposits over time. And potentially that leads to reversal of cognitive dysfunction in patients with Alzheimer's disease. So for most patients with dementia of whatever type it is really about managing the day-to-day, managing behavioral symptoms. So using systems and training of caregivers to be able to manage and take care of their patient in the home setting as much as possible, versus loading the patient with a lot of antipsychotic medications that may actually worsen symptoms. All right. That is a very brief overview of cognitive disorders. This was meant to just highlight some of the areas that I would encourage all of us to read in more detail, and also to listen to this lecture with the other lectures in this series. Thank you.